Hello, and welcome to our webinar series. I'll be brief today so that we can have more time for the webinar and the question and answer session. Today's webinar is about skin issues in vascular anomalies. Our presenter, Dr. Megha Tollefson, serves as consultant in a joint appointment within the Departments of Dermatology and Pediatric and Adolescent Medicine at Mayo Clinic, as well as being a member of the Rochester Clinic's Vascular Anomalies team. Among her many other appointments, accomplishments, and research endeavors, Dr. Tollefson is also one of the organizers for the KT Support Group meeting hosted at Mayo Clinic in Rochester, for which we're very grateful. My name is Melanie Finger. I am the director of the KT Support Group. We have an additional organizer today who volunteered her webinar expertise, Christy Collins of MCM Network. Today, Dr. Tollefson will address topics of interest for about 20 minutes. Then we'll entertain a less formal question-answer period. At any time during the presentation, you can enter questions in the chat box in your control panel. We will collect the questions, prioritizing and consolidating as needed. Any questions not answered, we will try to address via email or on the video posting. With no further delay, we're going to switch over to Dr. Tollefson.
Well, thank you very much. Thank you to Melanie and Christy and everybody for letting me share some information with you today. We're going to be talking a little bit about skin issues and complications in vascular anomalies, and this is meant to be really a pretty broad general overview, as Melanie said, a bit briefer so that we could have some time for some questions. So we'll talk about a lot of things, actually, even though it'll be brief, but about capillary malformations and port wine stains, about issues with eczema and cellulitis, ulcers and skin breakdown, skin cancer, general skin care, and cosmetic, a little bit on cosmetic camouflage. So hopefully this will be informational for everybody. These are really some of the more common issues that I think about, too, when dealing with and looking at the skin of people that have vascular anomalies and malformations. So this is just a cartoon of the skin. So this is a little bit of a cross-section of the skin, just showing how the blood vessels are sort of intertwined. And up here are where the capillaries are. The capillaries, of course, are what give rise to the capillary malformations or the port wine stains. When we have extra capillaries or in a localized area, that's what produces a port wine stain on the skin. So you can kind of see this drawing here. Looking at these capillaries under the skin, and then this picture of a port wine stain on the surface. So a little bit of that terminology, it's pretty confusing, it's always challenging, and it seems like a little bit of a moving target. One term that's thrown out a lot is hemangioma, and really what's the difference between a hemangioma and a vascular malformation. Even in the medical community, we're really trying hard to teach people the difference between these two, because as you've all probably noticed, the term hemangioma gets used quite a bit. And hemangiomas are actually referred to strawberry birthmarks or bigger growths that we call quote-unquote tumors, but tumors not necessarily in a bad way. And you can see that on the top right on that baby here. That baby has an ulcerated hemangioma. Everything else really is probably better classified as a vascular malformation. So really, we try to reserve the term hemangioma only for these specific sort of strawberry-type birthmarks. And then as far as port wine stains and capillary malformations, that's changing as well. And so what is the difference between the terms? And often they're used very interchangeably too. But I think one way to think about it would be that all port wine stains are capillary malformations, but not all capillary malformations are port wine stains. And we probably don't understand as much as we thought we did about these, and they're probably on a bit of a spectrum. So capillary malformation is probably the best term that we have. Capillary malformations also can take on various forms, and so they can be more reticulate. So like the picture on the right, you can see it as sort of a lacy purple-red birthmark. But on the left, you can see that it's really quite homogeneous and pretty even throughout and really not very lacy or broken up. And so this is just a little bit more dramatic picture. So on the left, a very more homogeneous, geographic, solid, basically a solid port wine birthmark, whereas on the right, you see more of that reticulated, broken up pattern. And then there's this other term called CMTC, or cutis mammarragia telangiectatica congenita, which a lot of the reticulated type of capillary malformations often get called CMTC. There really probably is a bit more of a distinction here, so you can see it's a little bit harder to see on the young baby, but you can see sort of a little bit more coarseness, and that's really apparent on the older child here. You can see that coarseness to the capillary malformation, which really leads to being more of CMTC. There are other things that are more commonly associated with CMTC that you don't necessarily always see with capillary malformations. In particular, you can get some erosions overlying the top, so some skin breakdown, and then you can also have atrophy of the tissues underlying these CMTC areas. So again, we talked about these are, capillary blood vessel malformations. There might be a lymphatic component associated with that or underneath it, even a venous component. They're usually present at birth, and they're really the most common congenital vascular malformation that we have. They can occur anywhere on the body, and when not associated with a particular vascular malformation syndrome, the most common place we see them is on the face, the head, and the neck. So one of the most important and biggest concerns with these capillary malformations or port wine birthmarks is that they can thicken up and form these blebs over time. Those that have a lymphatic component are probably a bit more likely to form these blebs, and some people believe that actually the blebs are more lymphatic vessels rather than the capillary vessels. So by the time someone's in their 40s, 2 out of 3 will have some thickening, and 1 in 4, or even more than that, depending on the study, could have blebbing. So you can see some more blebs there. And another couple of pictures of blebs. You can see that they're smaller on the left there, but on the right you can imagine that those are really pretty disfiguring and probably pretty troublesome too. Again, so blebs can happen really with these capillary malformations anywhere on the body. This is a little bit of a blurry picture, but it really demonstrates the thickening that you can see with the capillary malformations. And this is just to demonstrate how these can change over time. So, I said that most of the time, by the time you're in your 40s, you'll see the thickening in the blebs, but that can really happen early on too, depending on what's sort of lying underneath these capillary malformations. So the picture on the left here is actually this boy at birth, and you can see at 6 years of age how that capillary malformation has changed. It's gotten darker, a little bit thicker, and then a lot of blebs there, and those blebs tended to bleed nearly on a daily basis and was really fairly distressing to him. There's another one that you can see. This is a baseline sort of picture, and this is just 4 years later, so you can see how much thickening and more blebbing there was. So in addition to the blebs, what else do we worry about with port wine birthmarks or capillary malformations? Definitely dermatitis, and we'll talk about each of these a little bit more. You can form pyogenic granulomas, which are other different collections of blood vessels, and you can also have treatment-related complications with these capillary malformations. So capillary malformations and port wine birthmarks are particularly susceptible to overlying dermatitis. It may be that even though there are extra capillary blood vessels there, the skin is actually in fact compromised because those are sort of taking the space of the normal blood vessels you might want in that area. That's sort of one theory behind it. It can be really itchy, and so I often recommend that people keep these areas really well moisturized. And good moisturizers to use are something bland, like something that's cream-based, that doesn't have preservative or doesn't have fragrance. It may have to have a little bit of preservative. Ointment-based moisturizers, just like plain petroleum jelly, are really good moisturizers. They're just a little bit greasy. If there's enough dermatitis, you may need to use a topical steroid to help calm it down. And these areas definitely, not only are they susceptible to dermatitis, but they're also susceptible to allergic contact dermatitis. So the most common reasons for allergic contact dermatitis in an area overlying a port wine birthmark would be adhesive from different dressings and that sort of thing. There's another photograph that shows a really inflamed area of dermatitis in the center of that port wine birthmark. So this is one that I would certainly use topical steroids on, and then make sure the person's doing a really good moisturizing regimen and avoiding adhesives and fragrance and things like that as much as possible. And then pyogenic granulomas. So those are different vascular growths. They can be spontaneous, so anybody can actually get a pyogenic granuloma. They seem to be a little bit more common in children, even children that don't have capillary malformations. We think that it may be a response to trauma, or it may be a response to treatment. For some reason, it's also more common in pregnancy. But people will often come in with what we call the Band-Aid sign when they have pyogenic granulomas. They'll have a Band-Aid covering it because it's very friable and it really likes to bleed and gets really pretty annoying. But they can occur with more frequency over capillary malformations. So you can see here, these two areas that are circled in this capillary malformation are pretty friable. You can see that they want to ooze. These are in fact pyogenic granulomas. And again, another photograph there. So what do we do about these pyogenic granulomas when they come up? It's fairly straightforward. Most of the time, surgery is the answer, just a little bit of local anesthesia, and then we usually shave off the pyogenic granuloma and do some cautery at the base to try to burn off the blood vessels so that hopefully it doesn't come back. If a pyogenic granuloma occurs within a capillary malformation, it is a bit more likely to come back just because that tendency for the blood vessels to want to proliferate is still there. Different lasers, and we'll talk about one of the lasers in a little bit more detail, can be used for pyogenic granuloma treatment. A cream called imiquimod may be helpful, but it can be quite irritating, and so I do hesitate to use it in the setting of a capillary malformation. And then timolol, which is actually a topical beta blocker, it's used for glaucoma. We also use it to treat those infantile hemangiomas we talked about early on. That's been shown to be helpful in some pyogenic granulomas. There was just a recent study of 7 children that had pyogenic granulomas that responded to beta blocker treatment. So then a question looking at just the capillary malformation is, can we predict when someone has a capillary malformation who's more likely to have problems, who's going to have fairly few symptoms, and who's going to have trouble in general with different issues? And so there's a study that looked at the distribution and the type of stain, kind of like we showed early on. Is it blotchy and reticulate, or is it more sort of geographic and homogeneous? So this one actually would be a little bit more blotchy, and this one here would be more of a homogeneous capillary malformation. And again, I apologize for the blurry pictures, but it shows a little bit of the difference between what's geographic and what's considered to be more blotchy. And what was discovered is that those geographic ones, the ones that are more homogeneous, are more likely to have associated lymphatic malformations, more likely to have cellulitis, pain, and recurrent bleeding, and probably also more likely to develop blebs within them. So this is a little bit more of a diffuse one, not quite reticulate, but more diffuse than the other ones. And then another little bit more of a diffuse one. And this has been sort of categorized on the lower end of the spectrum of vascular overgrowth problems. And so the patchy and more reticulate ones are associated with a good overall prognosis, with no cellulitis, no blood or clotting problems, and they, such as in these babies, may have some overgrowth, but it's usually not progressive, and it's usually not terribly bothersome over a lifetime. So then looking at the capillary malformation itself, what can we do about it? The most common treatment when treatment is desired is laser treatment using this pulsed dye laser. And what the pulsed dye laser does, it has a specific wavelength that it uses, and that wavelength actually targets blood. And so the idea is that it targets the blood, so then destroys the blood vessel, but really minimizes damage to any of the surrounding tissues. And so it's what we like to use most when we treat different vascular birthmarks. It can be really helpful for treating blebs and for treating bleeding, especially if it's caught early on. It can be helpful for the treatment of thickening of capillary malformations also. And usually it does require multiple treatments, so it can be as short as every 4 weeks of treatment, as long as every 8 weeks, and sometimes people even go longer in between treatments, just due to practical issues. One question is, when should we treat? Is it better to treat early on, or is it better to treat later in life? And this was a question. This was up for a fair amount of debate. Some people really believe that the earlier treatment, the better. It probably does serve to prevent the thickening a bit better if people are treated earlier in life. But we definitely have to weigh the pros and cons of that with whether or not we have to use general anesthesia. There's some concerns that the younger you use multiple episodes of general anesthesia, the more likely a child is for long-term sort of developmental problems. So we really try to be cautious, and in the really young kids, try to do as much as we can without general anesthesia. Usually what happens is that someone undergoes treatment early on in life, usually sometime in the first 5 to 6 years. They do very well. They get to a point where they're very happy with the amount of lightening that they've been able to achieve. And then at some point during life, periodically, we do a little bit of touch-up. So it might be that every 5 or 10 years they come in and get 1 or 2 more sessions of the laser for touch-up. Another question I get a lot is who should we go to have these laser treatments? And generally, these types of lasers are probably best in the hands of a dermatologist or a plastic surgeon that's experienced in using this laser. Who's less likely to respond? When you have darker skin, you're a little bit less likely to respond. The thicker your stain, the little bit less likely you are to respond. And those that are not on the face or the neck, unfortunately, tend to respond less. So it's pretty rare that I actually treat a stain on the trunk or extremities purely for cosmetic reasons. Usually we quote that we can hope to aim for about 50% up to 50% lightening on the trunk and the extremities, and anywhere from 50 to 90% on the face or the neck. And it really just depends on the person. So here's one example of a capillary malformation. We showed this part of this gentleman's picture earlier on, but before and after treatment, you can see he's gotten a fair amount of lightening. This was after several sessions, actually. What problems can we get with treatment with the laser? In the short run, you can get a fair amount of pain, crusting, and blisters if the energy is overdone. That's why it's really important to have this done in the hands of someone that has experience using this laser. In the long term, if it's overdone, this can lead to pigment changes, especially the darker the skin that you have, and it can lead to long-term scarring. So we are pretty cautious. I tend to be pretty cautious in how much energy we use, at least early on in these laser treatments. You can see a before and after here of this young lady who's gotten some laser done. You can see in here a fair amount of improvement with the blebs. So it can be very helpful. Sometimes the laser treatment's just not enough, and so at least with the pulse dye laser. So we do have some other options. There are a couple of other lasers that have a bit of a different wavelength, and they may target the blood vessels a bit better, but they also have the option for a little bit more collateral damage, and so it could potentially do a little bit more damage to the surrounding skin. But there are so many lasers out there, and only some of them will actually treat the blood vessels, so we really want to focus on those. Rapamycin or sirolimus is a very hot topic, not just systemically, but also topically. And so in some capillary malformations, some people have theorized that we could potentially use topical sirolimus to help get some lightening. Topical sirolimus was first used in dermatology to treat this condition on the right, which you see these bumps basically on the skin that got better with the topical sirolimus, and this is actually tuberous sclerosis. So these are some growths that people with tuberous sclerosis get in the setting of their disease, and that responds fairly well to the topical sirolimus. And a lot of these kids and adults that were having to get laser treatment for them are having to get less laser because of it. Topical sirolimus may also be helpful in those areas that are pretty annoying, that tend to leak a lot, that we have a lot of trouble healing up. We do need to do some better studies on topical sirolimus to see how well it really works. But I have found some benefit in sort of the smaller lymphatic malformations that arise on the skin. It seems to be a really good use for the topical medication. This is a study looking at its use in Sturge-Weber. This was done in France. And what they did is they broke up each person's capillary malformation to 4 quadrants. And in part of it, they used topical sirolimus, and part of it they used laser, and part of it they used both, and in part of it they used none, no treatment. And what they found is that the area that was treated with laser and topical sirolimus tended to respond the best. So this is promising, although the jury is still a little bit out on the true use and utility of this medication. So this is a scenario where I really like to try topical sirolimus. You can see these blebs, they're not terribly out of control, but you can see here especially where it really does like to bleed. I found that topical sirolimus in this setting can be helpful in these little areas that really want to bleed and ooze. We'll just talk briefly about venous and venolymphatic malformations. They appear as a bluishness usually under the surface of the skin. Again, you can have lymphatic vessels in conjunction with the veins, also with the capillaries, and they can form a bit of a mass or a clump, and that might be the only thing that you see on the skin, or you can see some overlying sort of more dilated blood vessels or telangiectasias. So here's just a photograph of a straightforward sort of more venous malformation that doesn't have a lot of overlying skin change. And then this is a photograph just of the tip of the iceberg, kind of, so to speak, that you might see with lymphatic malformations. So you can see these areas, they really start off more clear, and then when they get blood into them or hemorrhage, they can look more red, like blood, basically. But what this indicates to me when I see it is that under the surface there's probably a fair amount of lymphatic malformation. This is another scenario where I really did try the topical sirolimus to see if that would help the blebbing. And this is a nice picture where you can see sort of all 3 of the components that we classically think about in KT, with the capillary malformation, the lymphatic component. You can see sort of those veins underneath the surface of the skin. This probably counts in the skin, but counts in other parts too, but superficial dermophlebitis can definitely be a big issue, which is just inflammation of the superficial veins. Happens in about probably 15% of patients with KT and other overgrowth conditions. Really, in general, treatment for that is very supportive. Ibuprofen, compression, and elevation are very important. Often it will go away within a couple of weeks, but it might not. And in those situations, especially if it's recurrent, vein stripping or sclerotherapy can be helpful, aspirin can be helpful, and even anticoagulation with low molecular weight heparin can be helpful in that setting. All right, well, we spoke about dermatitis overlying the capillary malformations, but you can also get a fair amount of dermatitis on the legs, especially if there's a lot of edema. So this is more of a venous stasis or lymphedema-associated dermatitis. And you can see all these photographs of pretty raw, open skin. What do we recommend for that? So again, topical steroids can be very helpful. It's definitely not a mainstay of therapy, but when you're particularly flared, that can be really useful. Good moisturization, again, with something thick and creamy or something greasy, elevating, continuing to use compression diligently. And then the risk, if it's not treated or if it's undertreated, it can lead to infection and ulceration. And as you can imagine, the blood supply in that area is fairly compromised to the skin, so it can take longer to clear the infection or ulceration if there were no edema in that area. So a little bit about compression. I got these compression pearls and compression from our physical therapist that does a lot of our lymphedema, and she wanted to relay that she really focuses on a proper fit, that the proper areas are covered. She says that often a mistake is more commonly to use too much pressure. Really, the mistake is not to use too little pressure, so she usually finds people that are getting overdone on their pressure. And then a really common problem is the areas that are painful because of the compression garment itself. And so they take a lot of care to make sure that the garment doesn't cut into the area of the malformations. They can fashion different types of garments so that if someone has an entire leg affected, but it's behind the knee that's really painful to compress, that they fashion more of a capri type garment and also a knee high, just to offload the pressure there. We can also use some thin foam or some medical type lambs wool to pad those areas that tend to get a little bit too much pressure. Cellulitis can be a huge problem, especially because of fluid pools. The blood return is impaired. Then that leads to impaired skin integrity. Little cuts in the skin that normally would heal quite well can lead to infection. Draining blebs and draining superficial lymphatic malformations can predispose you to cellulitis. And that can really result in a lot of redness, warmth, and pain. And a lot of people are able to tell that their cellulitis is coming on. And in that scenario, we often just have them have their rescue antibiotic at home, and they know to use it at the first sign of cellulitis. So there's some photos of cellulitis. Actively treating cellulitis is usually antibiotics by mouth and then rest and elevation of the affected extremity. And what can we do to prevent it? So really just good skin care, and we'll go over good general skin care towards the end, but bathing or washing it daily, doing bleach baths, which we'll talk about a little bit more, continued compression to treat any athlete's foot at its first sign, because athlete's foot leads to minor, small little breaks in the skin, which can be an entry point for bacteria. And then the question is whether or not topical rapamycin can help, as we talked about before. Ulcers can be a very big problem. I wish that I had a magic treatment or a universally effective treatment for ulcers, but it really is very dependent on each person. But we see ulcers mostly in the setting of a lot of swelling, mostly with the venous or lymphatic malformations with that impaired skin integrity. Long-standing dermatitis that's not under good control can lead to ulceration. You can also see a lot of ulcers in the post-procedure setting, whether if it's surgery or sclerotherapy. So that's a time for really proactively keeping on top of skin care and wound care is in the post-procedure setting. We do often work with our wound care clinic for specific dressings and ideas on how to either treat ulcers or to prevent ulcers if someone's more prone to ulceration. So there's another one. Kind of some of the same things we talked about. Whirlpool therapy can also be helpful. We do that in our wound care clinic. It provides some gentle debridement without using sharp instruments. Wet dressings can be helpful in the treatment of ulcers, basically a warm compress. Sometimes I'll have people put a little bit of dilute acetic acid solution in their wet dressing solution. Acetic acid also has some antiseptic or antibacterial properties. And then in really severe settings where we're not able to make any headway, we can use hyperbaric oxygen to help the ulceration heal. All right, so just briefly on skin cancer, I know this is a topic some people were interested in, and there's not a lot out there, but there is some. So skin cancer has been described in a handful of cases. One of the more common scenarios is as a complication of ulceration. So long-standing ulceration can increase your risk of developing skin cancer. Mostly we think about squamous cell carcinomas in that setting. There have been some reports of rare, just very spontaneous skin cancer development within port wine birthmarks or capillary malformations also. So squamous cell carcinoma, as we talked about, a risk factor is long-standing ulcers and whether or not there's been any radiation therapy in that area. And unfortunately, sometimes it really just looks a lot like the ulcer, and so we really do have to have a high index of suspicion when suspecting this. That's unfortunately also balanced with not doing unnecessary biopsies, because the more biopsies we do, the greater the chance that you're going to end up with a sore that you can't heal, especially if there's poor circulation in that area. But if squamous cell carcinoma is found, it is treated with surgery, and the amount of surgery really depends on the scenario. And then another kind of blurry old picture, but basal cell carcinomas have spontaneously developed within port wine stains and birthmarks in the past. These are just a handful of cases, and just really more standard surgical treatment for those. And then more recently, angiosarcoma has been reported. So angiosarcoma, we know one of the risk factors for development of that is long-standing edema, and the most common setting that it's seen in that scenario is in people that have had breast cancer, that have had radiation, and then they have a lot of lymphedema in that area due to their surgery. That's a place that we're very suspicious of angiosarcoma in general. But there have been a couple of cases of people with KT who have really pretty severe edema and lymphedema that have had angiosarcoma develop within it. And again, I would say it's just really to maintain a high level of suspicion. If there's a lesion there that's different than normal, if it's not healing, it's not going away. Okay, we're almost done here, and then we'll have some time for some more directed questions. But what do I recommend for good routine skincare? Really, it's bathing daily or cleansing the affected area daily as possible. Just use a very mild, gentle soap. I don't really like to recommend a lot of like Irish Spring or Dial or things like that in general for most people because it can be irritating to skin that already likes to get irritated. Daily moisturizing is very important, even multiple times a day in an affected area if it's prone to dermatitis. Again, treating the first sign of athlete's foot. To treat dermatitis proactively and not to try to wait it out. And then bleach baths if you're predisposed to infection. And the general rule of thumb for that is half a cup of regular plain household bleach to every full bathtub of water. And for a child, that might be a quarter cup to every half bathtub of water. This was just from the study that was done on bleach because it's clearly a question that many parents especially and many people, when I mention it, they're kind of taken aback by being told to put bleach in their bath water, in their child's bath water. This was the initial study on bleach baths, and this was actually in eczema patients. But if you see here on the left here, this is a marker for the number of bacteria on the skin. And with minutes in bleach, the more minutes you have in bleach, the less bacteria there were. And then when actually treated in people, those that got the actual treatment with bleach had much less bacteria over time than those that got the placebo treatment. And then just a minute on skin camouflage. I really like this use. It really depends on where your vascular malformation is and how big it is. But if you have a smaller one that's in an area that's coverable, skin camouflage, cosmetic camouflage can be really helpful. And you can see these before and after pictures of people with various skin conditions, a tattoo and then pigmentation that's really nicely covered. This is from an article that looked at kids, mostly girls, that had different skin conditions. And you can see a port wine birthmark here, but using a capillary malformation here. And you can see that cosmetic cover-up can actually really help cover up these areas, make it really blend in with the other skin. And I like to show this picture because this is a commercial from one of these companies that sells these products. This is what this man's skin actually looks like, and with the cover-up, this is what he looks like. So it's really quite dramatic. So that was all I have for slides, and we can answer some questions too.
Okay. Hi, Megha. Thank you very much. That was wonderful. And I have a few questions that have been sent in previously. Safe hair removal for KT-affected limbs.
Yeah, so that is one of those practical questions that's important. So in general, KT-affected limbs are a little bit more compromised, more prone to sensitivity and skin breakdown. So really, the gentler the method of removal, the better. Unfortunately, there are not a lot of gentle hair removal techniques, but I would recommend just using a razor, actually, one that you can trust doesn't nick you. And another way to ensure that you don't get as many nicks is actually shaving with the grain is better than against the grain. It's a little bit counterintuitive. You probably don't get as clean of a shave, but it's safer. And then always use a product such as a cream or a gel. There are some really good more sensitive products out there that are shaving creams. Vanicream makes a product. Aveeno makes a product that people with sensitive skin tend to tolerate a little bit better. But some of those depilatory creams, waxing, things like that, it's probably just a little bit too aggravating for many people that have KT, women.
Okay. Yeah. Okay. And this is a question about treating, and this really has to do, I guess, with moisturizers, but the severely cracked and calloused skin that is actually on the port wine stain. Is that something that you would just use a regular moisturizer on?
Yeah, definitely regular moisturizer, but that might actually need some topical steroids. So even if there isn't a lot of itchiness, if it's cracked, some topical steroids, so a medium strength one, such as triamcinolone, and you would have to have a prescription for that, can really help to heal up those cracks. And then moisturizer, absolutely. And when there is a lot of cracking, I strongly prefer ointment-based steroid medications and ointment-based moisturizers because they sting less. So Vaseline or petroleum jelly is a fantastic moisturizer and it's cheap.
Okay. Thank you. And let's see, you did skin care and wound care. I think that's, bug bites.
Bug bites. Well, I think, everyone's prone to bug bites, and depending on each different person, they're more susceptible to having reactions to bug bites. Preventing bug bites, I think, is the same as with anybody else. What I tell all of my patients to prevent bug bites is to use a bug prevention spray, and DEET is probably the best to prevent both mosquitoes and ticks. I usually recommend about a 20% concentration. If your goal is only to prevent mosquito bites, then picardin, which is an ingredient that has recently been approved here, but it's been used in Canada for a long time, is probably equally as effective as DEET and might have less of the concerns of toxicity associated with it. So.
Okay, and if you get a bug bite, what do you put on it?
If you get a bug bite, really, it's probably not that much different either. If you get a bug bite overlying your KT or your capillary malformation, it's possible that with the itching, you cause a little bit more damage than an unaffected skin. So you really want to be a little bit more proactive about controlling the itch. And really, to control the itch, I recommend antihistamines. So Benadryl, Zyrtec are really good just to use while you're affected with the bug bite and it's itchy. Some people that tend to have recurrent bug bites and really get quite a bit of symptoms of itching with them, I'll have them actually use those medications throughout mosquito season. They're really safe and they're not habit forming. You can use some topical steroid if you have sort of more limited bug bites, and that can really help with the itching as well.
Okay, wonderful. Does anybody in the audience have any questions? Do you type them in your chat box? Why would a port wine stain become lighter in color?
Mm-hmm. Yeah, that's a good question that I don't think we have a very good answer to, but you're absolutely right that there are some capillary malformations and port wine stains that become lighter in color rather than darker in color over time. I tend to see that a little bit more with the more reticulate malformations, and there is really quite a spectrum. And so if you think about like a salmon patch or an angel kiss, those are birthmarks that are also capillaries, but they tend to get lighter over time in almost all people. And the theory behind that is that the nerves that control those capillaries are not mature at the time of birth. And as they mature, they're able to let those capillaries clamp down a little bit more. And so I think that's a leading theory, that in those capillary malformations that get lighter, that might be part of what's happening, is that the nerves in that area are maturing.
I thank you for coming, and we will end the webinar now. Megha, thank you very much.
Oh, you're welcome. Thank you.